Hey guys, okay, so this is the video on obstructions. This is the very beginning of chapter 56, and it should be page 1122 in your textbook, in our textbook. This upcoming test is over 10 chapters. That is a lot of material. Okay, off we go. So obstructions can be classified in two different ways. We have mechanical and non-mechanical. So mechanical obstructions are obstructions that are physically blocked by something. So something outside the intestine. So adhesions, tumors, Crohn's, those types of things. The mechanical obstructions are going to be things like paralytic ileus, something actually fundamentally wrong with the intestine. So for the obstructions, complications that we want to watch for are going to be fluid and electrolyte imbalance, which can lead to metabolic alkalosis or metabolic acidosis. We also want to watch patients for hypovolemia, bacterial peritonitis, which they're at increased risk from if they have strangulated obstruction. We also want to keep an eye on them for sepsis and hemorrhaging. And then as far as the sepsis and hemorrhaging, that can lead to an increase in intra-abdominal pressure or acute compartment syndrome. So as far as the etiology of each one, that is very different. So with the mechanical ones, it's going to be like there's a pretty long list in our book, but it includes adhesions, tumors, Crohn's, appendicitis, hernias, fecal impactions, intussusception, volvulus, fibrosis, vascular disorders, and diverticulitis. For the non-mechanical ones, we're looking at post-op ileus or paralytic ileus, handling of the intestines during surgery, and then peritonitis, as well as intestinal ischemia. So I guess for non-mechanical, you really want to think of things that are like inert to inertly affected by the actual structure of the intestines. So as far as assessment, we want to assess for several things. A classic symptom of obstruction is actually hiccups. So I thought that was interesting. But assess for nausea, vomiting, abdominal pain if they have a previous any previous surgeries or history of GI disorders, blood in their stool, changes in bowel habits, if they have a temperature, flatus, and definitely want to keep them MPO if you think there's an obstruction. And then in chart 56-1, that gives us the key features of small bowel obstruction versus a large bowel obstruction. So take a peek at that. And then some other symptoms we want to look for. Patients may be tachycardic with hypotension, abdominal pain, abdominal rigidity, and then the color of the overlaying skin over the abdomen. And then they may have obstipation, which is no passage of stool. Also abdominal distension and peristaltic waves when we do our inspection. Obviously, don't palpate or percuss if you think there's an obstruction. She went over that in class. But something else to look for is borborygmi. Those are high-pitched vowel sounds. So also with the non-mechanical obstruction, the pain is usually going to be constant and diffuse. So as far as labs, we're going to look at for a strangulated obstruction, they're going to have leukocytosis, so the increase in white blood cells. They'll also have elevated hemoglobin, hematocrit, creatinine, and BUN. And then they're generally serum, sodium, chloride, and potassium are going to be decreased. And then for confirmation of the obstruction, we can do CT, MRI, and to find the cause, they could also do ultrasound, colonoscopy, or sigmoidoscopy. But ultimately, our goal is to remove the obstruction and find the cause. So there is another chart in this section, chart 56-2, and that one gives you the nursing care of intestinal obstruction patients. And I'll just kind of go over those because that would be a really great static question too. So we're going to monitor vital signs and fluid balance every 2 hours. Assess the abdomen twice a day, and that's going to include bowel sounds, looking for distension, and then also asking the patient about flatus. We're going to monitor fluids in labs, and then manage their NG tube if they have one. Also manage their pain, and then parenteral nutrition, and then alvimopan for post-op ileus. That's the only drug that is mentioned in that box. So just be aware of the name, familiar with the name, I think. If they have an NG tube, it's going to be to decompress the bowel. And then we're going to assess the NG tube every 4 hours for placement, patency, and output. So just in general for our NG tube patients. Also monitor for flatus and bowel movements, IV fluid replacement and maintenance. And then these patients should generally be thirsty, but if they're elderly, they may not be thirsty, even though they're dehydrated. So that's something to keep an eye on. And then we can actually delegate mouth care to our UAP. So that's your delegation for that section. And then we want to keep that patient in the semi-Fowler's position. And then also something that patients or their family may not understand that we should explain if it happens is sometimes for diagnoses, the doctor can withhold opioid analgesics because obviously they cause constipation, and so we may have to hold that for their diagnostic workup. And so we need to explain that to the family and the patient so they know why we're doing it. Also, they may or may not end up with a colostomy, just depending on where the obstruction is. And then as far as surgical interventions, they can do an exploratory laparotomy, and just kind of investigate what's going on in there. And then if they do find any adhesions, those can be cut and released. However, if the obstruction is caused by a tumor or diverticulitis, then that part of the intestine is usually resected. So As far as post-op or sending the patient home, they need to report to us any pain, distension, nausea, or vomiting. And then we need to teach them incision care, drug therapy, and then activity limitations. We don't want to increase that intra-abdominal pressure. So generally patients are given Percocet and then weaned, tapered from that, and then to less serious pain medications, and then are also given laxatives or stool softeners. So that's the main stuff for the bowel obstruction patients. And then let me know if you guys have any questions or if I forgot anything. And we will move on to the next section. Thanks. Bye.